call the next presenter, Dr. Naila AFTAB. She'll be talking about multimodal imaging of choroidal effusion in a case of nanophthalmos. So first we will mark them up.
We'll call them back if we have time,
Otherwise we'll mark.
Good morning, all. I shall talk about multimodal imaging of choroidal effusion in a case of nanophthalmos. So, to introduce with, nanophthalmos is one of the clinical phenotype of simple microphthalmos. That is, there is a shortening of anterior segment and posterior segment, along with a cutoff of less than 21 mm of axial length. So, there is a stagnation of development of eyeball after the closure of embryonic fissure. Hence, these patients don't have any ocular abnormality and systemic anomalies. They have shorter axial length, shallow AC, and increased lens to eye volume ratio, which is more than 11%, and normally it is 4%. And they have clinical risk of hyperopia. They have high hyperopia, hence they have clinical risk of severe amblyopia, RD, and cataract. So to begin with, we had a male patient in his late 20s who presented with complaints of diminution of vision, which was since early teenagehood, which has increased in the past 6 months. So the vision was finger counting 2 meters and hand movements with inaccurate PR. He had RAPD in left eye, clear lenses, shallow AC in the both the eye, and the AR showed a refraction of plus 16 and plus 17 diopters. IOP on application tonometry was 14 and 44 mm of Hg. The fundus examination showed in the right eye only blurred temporal margin, whereas in the left eye he had near total cupping along with deep tunnel-like cupping with optic disc crowding, macular folds, subtle macular folds, and deep dot and blot hemorrhages. So this imaging shows the patient had a steep cornea with axial length of 16.8 and 16.5, high lens thickness, and ACD was shallow. And IOL power calculation according to Hoffer Q was 47 and 49 diopter. And here we can see that the patient has shallow anterior chamber and congested anterior segment. This is the IR imaging of both the eyes, fundus imaging of both the eyes. In the right eye, both the eyes, we can see there was optic disc crowding, whereas in the left eye, we can see there's deep tunnel-like cupping with subtle macular folds also. And OCT line scan of the fovea was done to calculate subfoveal choroidal thickness, which is around 230 in the right eye. In the left eye, it was around 480 microns. And CMT of the right eye was 408, and the left eye it was 446. In the left eye, we can see there was thickening of the inner retinal layers also. B scan and UBM was done to look for changes in RCS thickening. And here in the left eye, we can see the blue arrow shows the subtle choroidal effusion. And the RCS thickening in the right eye was 1.9, and in the left eye, it was around 2.02. And right eye showed angle closure in the superior, and the left eye showed occludable angle in both superior and inferior angles. So the patient had uncorrected hyperopia to begin with, which led to severe amblyopia, and later on he developed angle closure glaucoma, which has gone to chronic stage, leading to glaucomatous optic atrophy in the left eye, which further led to choroidal effusion and led to visual debilitation in the left eye. So he had optic atrophy in left eye and irreversible amblyopia in both the eyes. So why does choroidal effusion occur? Because of abnormal collagen in the sclera, which led to increased scleral thickness, making it inelastic, impairing the vortex vein outflow, leading to choroidal effusion, and which further could lead to RD. So salient points in diagnosis of such condition is that these patients will have steep cornea, shorter axial length, smaller the axial length, higher the complications. They have high lens to eye volume ratio. Normally it is 4%, and nanophthalmos it is around 11 to 32%. Increased SFCT, increased CMT, macular folds, hypoplasia of foveal avascular zone, and increased scleral thickness, which can be seen on ultrasound B scan with RCS technique of more than 1.7 mm. So lack of generalized consensus for diagnosis of such cases is make it little tricky. We should have an early recognition and management pattern for such cases. We should educate these patients about the disease course and tell them about the warning signs. And lifelong management in terms of prescription glasses to give amblyopia therapy is important, along with glaucoma control. Thank you.
Thank you, Dr. Naila. Any questions?
So did you do anything for the left eye?
So we started the patient on oral steroid, but he was later lost to follow-up. So we couldn't image him further.
Okay. What would you have done for controlling the IOP in the left eye?
So we could have done posterior sclerectomy also. And he was started on AGM, and if not responding, posterior sclerectomy along with trap could have been done.
So the AC must have been very shallow, right?
Yes, sir.
So a trap failure rate would be very high. What else probably would you have done?
GDD could also have been tried in past planner route.
Maybe again in our clinical experience, we feel that because the lens is of a normal thickness and the rest of the eye is small, removing the lens,
Could
putting a
also have
IOL
helped. Yes.
that deepens the AC and increases. A lot of patients actually have a very good IOP control just by opening up of the angles, and if it doesn't open up, then filtration surgery would be much more reliable in terms of long-term efficacy. So without that, and the second thing you said was scleral flaps. Sorry. So that is meant for congestion. It really doesn't help in glaucoma as far as I know.
So I personally do a sclerostomy in these kind of patients, a 2.5 by 2.5 sclerostomy posterior. It helps at times.
In
along
glaucoma
with
also.
cataract surgery.
In glaucoma control also.
No, not in glaucoma
That is
control,
for
but in normal
congestion, UV
patients.
effusions. Okay.
So I operated a 52 power patient a few days back. I did a sclerostomy, the patient is doing well. The AC deepens, the IOP is usually well controlled.
Okay.